Hello everyone, welcome to the new session in CVS pathology. Today we are going to discuss two important topics. One is aneurysm and the second a life-threatening condition, that is aortic dissection. So first let us see what is this aneurysm. See, aneurysm I have already told in the previous session, it is nothing else but an abnormal dilatation. Okay, see the words are very important. It is nothing else but an abnormal dilation of the blood vessel or even the heart, okay, which may be either congenital or acquired. And I have already told in the previous video that in aneurysm, what is the pathology? The pathology is at tunica media. The pathology is at tunica media. Fine. So we have something called as true aneurysm, false aneurysm, or pseudo aneurysm. What is true aneurysm? See, when this aneurysm involves an intact arterial wall, we call it as a true aneurysm. For example, atherosclerotic aneurysm, syphilitic aneurysm, congenital vascular aneurysm, ventricular aneurysm. Okay, all these are types of true aneurysm. What do you mean by false aneurysm? False aneurysm means because of some defect. See, in true aneurysm, the vessel wall is intact. Whereas in case of false aneurysm, there is a defect in the vessel wall, as a result of which, what will happen? There will be leakage of blood leading to hematoma formation. You know hematoma? Yes, you have read in anatomy, subdural, subdural, subarachnoid, and hematoma is nothing else but what? Accumulation of blood in the interstitium. Am I right? Yes. So there is an extravascular hematoma. This will freely communicate with the intravascular space. Am I right? So that is what we call it as a false aneurysm. So what is the basic difference between true aneurysm and false aneurysm? In true aneurysm, the vessel wall is intact. Fine. Whereas in case of false aneurysm, also called as the pseudo aneurysm, there is a defect in the vessel wall. Because of this defect in the vessel wall, there will be an extravascular hematoma formation. This extravascular hematoma will freely communicate with the intravascular space. Okay, that is why, since there is a communication between the intravascular and the extravascular compartment, wherever in our body, whether in all those areas or in whatever regions in our body, whenever there is a communication between an intravascular and an extravascular compartment, there will be always transmission of pulsation from the intravascular compartment to the extravascular compartment, and that is the reason why this aneurysm is also called as a pulsating hematoma. Okay, yes. What are the examples of this false aneurysm or the pseudo aneurysm? I told you in true aneurysm, what are the examples? Atherosclerotic aneurysm, syphilitic, ventricular, or congenital vascular aneurysms. All these are examples of what we call it as true aneurysm. See, per se, this aneurysm is so far it has been not asked as any short note or question, but since you have to challenge of solving the multiple choice question, you should remember what is the difference between true aneurysm and false aneurysm and examples of the false aneurysm. I says that what is that? False aneurysm is nothing else but what? There is a defect in the vascular wall. So in case of ventricular rupture after myocardial infarction, what will happen? There will be leakage of blood, and that will be leading to hematoma formation. Finally, what is the type of hematoma? It is a pulsating hematoma, and the aneurysm thus formed is called as a false aneurysm or pseudo aneurysm. Okay, yes. Okay, then by macroscopic shape and size, see, this is the normal vessel. This is the normal vessel. Okay, this is the normal vessel. And remember, I told you the true aneurysm. See, this is the false aneurysm. We will come to true aneurysm. See, the false aneurysm, there is a defect in the vessel wall. There is an extravasation of the blood. There is a formation of what we called as an extravascular hematoma. And so the pulsations, which is what exerted by the blood within the artery, it will get transmitted to this hematoma also. So this is called as pulsating hematoma. What is the name of this? Pulsating hematoma. See, this picture itself is very self-explanating. That among the true aneurysm, based on the macroscopic appearance of the aneurysm, we have some different types. One is what we call it as saccular aneurysm, and another one is called as fusiform aneurysm. See, the name indicates. What do you mean by saccular? That means only a part of the vessel wall is involved. Okay, when only a part of the vessel wall is involved, we call it as saccular aneurysm. When whole of the vessel wall is involved, we call it as fusiform aneurysm. See, this is I am going to draw the shape of a saccular aneurysm. See, this is a saccular aneurysm. What about fusiform aneurysm? The whole vessel wall will be involved like this. So these are examples of what we call as saccular as well as fusiform aneurysm. Okay, yes. So saccular aneurysms, they are nothing else but some outpoaching which involves only a portion of the vessel wall, whereas the fusiform aneurysm, they are diffuse, circumferential, they include a very long vascular segment. Okay, yes, fine. So these are two of the types of true aneurysm. These are two types of true aneurysm. So remember, we have true aneurysm and false aneurysm. True aneurysm, intact vessel wall. False aneurysm, there is a defect in the vessel wall. Among the true aneurysm, saccular, whenever there is an outpouching, each involves only a small portion of the blood vessel, and the second one is called as fusiform, when whole of the blood vessel, or I can't say whole of the blood vessel, a long vascular segment of the blood vessel is involved. Okay, that mainly involves what all arteries? Aortic arch. Okay, very very important. Aortic arch, then abdominal aorta. Okay, and even the iliac arteries. Fine. Remember, very very important question. In last session also I have told the order in which the atherosclerosis is affected. The descending aorta, fine. Yes, the lower portion of the abdominal aorta, then iliac, coronary, and the least is the circulophilis. Please remember that order. It has been repeatedly asked. Fine. See, in fusiform there will be a circumferential and a diffuse direction which includes a very long vascular segment. Okay. Now let us see what is the pathogenesis. What is the pathogenesis? See, the aneurysm is mainly because of defect in the structural integrity of the vascular wall. Whenever the structural integrity of the vascular wall is compromised, what will happen? There will be abnormal dilatation. I told you the problem is in the tunica media. So the intrinsic quality. So there are some 2-3 factors are responsible for this. The number one factor, what I am going to tell is that the intrinsic quality of the vascular wall is poor. For example, in Marfan syndrome, already studied Marfan syndrome. It is because of fibrillin gene mutation, which leads to some aberrant transforming growth factor beta activity, and because of that there will be weakening of the elastic tissue. Am I right? Yes. So that is one condition in which the intrinsic quality of the vascular wall is poor. That is what is the name of the condition? Marfan syndrome. The second condition is called as Lewis-Dietz syndrome. It is again another congenital disorder in which there will be mutation in the transforming growth factor beta receptors. Very very important. In Marfan syndrome, it is the TGF beta gene is mutated, whereas the receptors are affected in case of Lewis-Dietz syndrome. And this question has been asked in JIPMA a few years back. Okay, what is the abnormality in Lewis-Dietz syndrome, or what is the vascular pathology which was seen in Lewis-Dietz syndrome? The answer was aortic aneurysm. Fine. So there will be defective synthesis of elastin as well as collagen. So in both these, as well as remember, we have type 3 collagen synthesis is affected in case of our vascular type of Ehlers-Danlos syndrome. What is the classification we will use for Ehlers-Danlos syndrome? Yes, can anybody tell? Yes, type 1, type 2, type 3. Yes, what is the name of the class? That is called as Wilfrangi classification. What is it called as? Wilfrangi classification. Okay, I'm writing here. Wilfrangi classification. Wilfrangi classification is what we use for Ehlers-Danlos syndrome. Wilfrangi classification. Fine. Okay. Then in case of vitamin C deficiency, there is a defect in cross-linking of collagen. So in all these conditions, the intrinsic quality of the vascular wall is affected. Can you tell? Again, Marfan syndrome, TGF beta activity, abnormal. Then Lewis-Dietz syndrome, TGF beta receptor mutation. Ehlers-Danlos syndrome 3, and fourth one is vitamin D deficiency, C deficiency or scurvy. Then the second factor is that the balance of collagen degradation and synthesis is altered. There is a very very important protease called as matrix metalloproteinase that is responsible, okay, for degradation of collagen. So whenever there is an increased expression of this matrix metalloproteinase, what will happen? There will be more degradation of the collagen. Am I right? That will leads to what? That will leads to vessel wall weakening. Fine. So that is the most important thing. Or I can say decreased expression of tissue inhibitors of metalloproteases. What are tissue inhibitors of metalloproteases? These are the proteins which is going to inhibit MMPs. So when the inhibitors are decreased, or when this enzyme itself level is increased, what will happen? In both conditions, there will be degradation of the vessel wall, so leading to weakening. See? Okay. Then Then what is that? I told you that. So this is the second thing. The third thing is that the vascular wall can be weakened through loss of smooth muscle cells. I know, you know that the tunica media is mainly composed of smooth muscle. Whenever there is a loss of the smooth muscle cells, what will happen? What will happen? Again, this is going to cause what? The vessel wall weakening. So I am telling how that can happen, how the smooth muscles can be lost. I told you that whenever there is atherosclerosis, aneurysm is one of the complications of atherosclerotic disease. Last session I have told you, whenever there is what is atherosclerotic plague, the pathology is at the tunica intima. So at the tunica intima, whenever there is an atherosclerotic change, there will be recruitment of smooth muscles. From where the smooth muscles comes? The smooth muscles come from the tunica media. So whenever there is a change, ischemic change, which is going to affect the tunica intima, there will be recruitment of smooth muscle cells, smooth muscle cell proliferation all occurs at the intima. But the thing is that these smooth muscles are going to come from the tunica media. So the number of smooth muscle cells which is present within the tunica media is going to decrease, which will gradually, definitely it will, it will lead to tunica media weakening, finally leading to aneurysm formation. So histologically, what are these changes collectively called as? This is called as cystic medial degeneration. Very, very important BVIP point. This is the single histopathological hallmark point you have to remember in aneurysm. What is this cystic medial degeneration? See, you can see in this picture. Okay. So this is the normal way. Okay, this is the red color. This is the normal way in which the collagens will be, the elastin fibers will be straightly arranged. In Marfan syndrome, you can see there is irregular or a haphazard arrangement. Okay, haphazard arrangement. That means the elastic fibers are not arranged regularly. They are haphazardly arranged. So these are called as elastic fragments. Okay, yes. So you can see in this picture there are some areas. Okay, I'm going to rub all this. Okay, you can observe clearly. I'm going to draw with blue color. There are some areas. See, there are some areas in the tunica media, okay, which are devoid of these elastin fibers. So they appear in the form of what we call the cyst. That is why this is called a cystic media. That means in the tunica media degeneration, cystic medial degeneration. So I hope this is very clear for you. Yes, okay. Then remember, what are the two most important causes of aortic aneurysm are atherosclerosis and hypertension. So see, I told you that the circle of Willis is very least common to have undergo atherosclerosis. But remember, berry aneurysm, which is nothing else but the aneurysms of the circle of Willis, okay, or the aneurysm which is forming as a result of infection, we call it as mycotic aneurysm, ascending aorta aneurysm. All these are very common. See, in circle of Willis, the atherosclerosis change is very it's like uncommon. But at the same time, the aneurysms of this circle of Willis is very common. It is the rupture of this berry aneurysm that is one of the most important cause of the life-threatening condition called as intracerebral or intraventricular hemorrhage. Fine? Yes. Okay. Next, the most important thing what we are going to discuss is abdominal aortic aneurysm and thoracic aortic aneurysm. Out of that, the most important one which needs, when they ask about aneurysm, this is the aneurysm you have to explain in detail. That is abdominal aorta aneurysm. See, you can see this picture. This is an external view and this is the cut section. Okay, the cut section opened view. You can see that. See the abnormal persistent dilation. You can see the abnormal persistent dilation of the lower part of the abdominal aorta. See, this is how it bifurcates into the iliac. Am I right? Yes. So all this you know. Fine. Okay. So one of the most important causes of abdominal aorta aneurysm, the answer is again atherosclerosis. Okay. What is the most important cause of abdominal aortic aneurysm? Aorta aneurysm. Again, the cause is atherosclerosis. What is the other cause? I told you that is hypertension. Fine. See, then coming into morphology. See, morphology, we are going to what are the types of abdominal aorta aneurysm. This is one of the most frequently asked question. Okay, the question of interest for Central Institute exams. Okay, yes. So morphology, I told you, you have to know the location. In abdominal aorta, we have lot of parts. See, usually it is the aneurysm occurs below the renal arteries. Very, very important point. Okay, you have to remember this point. It occurs below the renal arteries and above the bifurcation of aorta. This is classically we have seen. Okay, this is above the bifurcation of aorta and this is below the origin of renal arteries. Fine? Yes. And it may be either saccular or fusiform. When only small portion is involved, saccular. When a long vascular segment is involved, we call it as fusiform. Okay. Then the aneurysm, it has a bland, laminated, poorly organized mural thrombus. That is what you are seeing, you know, this red color thing. This is what we call as the mural thrombus. Fine. Okay. Then what are the variants? Number one is inflammatory type. Inflammatory type occurs in younger patients who are having elevated inflammatory markers like C-reactive protein. They are characterized by histopathologically abundant lymphoplasmacytic inflammation with macrophages, okay, and there will be peri-aortic scarring, okay, there, because of inflammation finally there will be scar formation, okay. These are the important point. So it occurs in younger patient who have very increased elevated inflammatory markers like increased C-reactive protein, that is they are characterized by abundant lymphoplasmacytic inflammation with many macrophages, okay. Yes, so these are the points you have to remember in inflammatory type. Then another subset of this inflammatory AAA is nothing else but a vascular manifestation of a recently recognized, I have discussed about this in immunology, am I right? Immune system, what is that? IgG4 related disease, okay. So IgG4 related disease is characterized by high plasma levels of IgG4 and tissue fibrosis, okay, with the infiltration of IgG4 expressing plasma cells. So what they recently found is that in some cases of inflammatory abdominal aorta aneurysm, there is increased infiltration of IgG4 expressing plasma cells, okay, into the tunica media. Fine, I hope that is clear with you. It's a variant of, it is a subtype under inflammatory type. Then we have something what we call it as mycotic. Mycotic means I have already told you infection. So with it has some organisms, it will destroy the tunica media, which will cause a rupture. Okay, mycotic aneurysm always tends to rupture. So what are the clinical features? It may rupture into the peritoneal cavity or retroperitoneal tissues, which leads to potentially fatal hemorrhage. Okay, it may cause obstruction of the vessel, which branches off from the aorta, which may result in some ischemic injury. Am I right? Because of the thrombus, everything, it will obstruct. So it will cause kidney, mesenteric ischemia, vertebral artery, spinal cord, all those will be affected. Because you know, abdominal aorta is the major blood supply to almost all the abdominal and pelvic organs. Then embolism from this atheroma or mural thrombus. Whenever there is a thrombus is formed, it has very high chance of getting to what dislodged to some other places, okay. Yes, or sometimes this aneurysm may compress the adjacent structure like ureter or vertebra. Fine, okay. Then thoracic aortic aneurysm, they are most commonly associated with hypertension. Abdominal aortic aneurysm are most commonly associated with atherosclerosis. In Marfan syndrome, okay, Lewis-Dietz syndrome, I told you that is TGF receptor. Lewis-Dietz syndrome is TGF receptor mutation. Fine, there will be respiratory difficulty in swallowing, compression of recurrent laryngeal nerve, okay, all those stuffs. Fine, that's not that important. Just remember one thing: thoracic aorta aneurysm is seen in Lewis-Dietz syndrome, Marfan syndrome associated with hypertension. See, okay. Next, another most important point, okay, a frequently asked question that is asked is aortic dissection. Now let us see what is this aortic dissection. See, what is aortic dissection? Dissection, that means the blood will separate the planes of tunica media and it forms a blood-filled channel within the aortic wall. See, for example, this is aortic, so this is the blood vessel. This is tunica intima. I am drawing tunica media a bit in blue color. This is tunica media. So this is intima. The blood vessel will dissect through this tunica media. Within the tunica intima, and within the tunica media, it will form another channel, okay, of blood or another column of the blood. So it is called as like a blood within a blood vessel. Am I right? What is that? Blood within a blood vessel, or a canal within a canal type. That means it will pierce the tunica intima, it will pierce the tunica media, it forms a separate channel or a column of blood within the tunica media itself. This is called as aortic dissection. It occurs in age groups 40 to 60 years with uncontrolled hypertension. That is the most important risk factor. Or any connective tissue disorders, Marfan syndrome. It may be even iatrogenic, that means following a treatment in case of coronary artery catheterization, cardiopulmonary bypass, everything. Fine? Yes. Yes. Here comes a MCQ question. Okay, here comes the MCQ question. Fine. I told you that atherosclerosis. Remember, the dissection, aortic dissection is not that much common in conditions of tunica media scarring. whenever there is a scar formation in the tunica media as a result of atherosclerosis, this dissection is unusual. Why? Because this scar, or the tunica media fibrosis, it will inhibit the propagation of this hematoma. Am I right? Since the fibrosis is there, the blood cannot penetrate this fibrosis and forms a channel within the tunica media. So, pathogenesis, again, hypertension is the major risk factor. Very, very important point. Hypertension is the major risk factor for aortic dissection. So far, I have told one more condition where the hypertension is risk factor. Can you name what is it? Very good. It is thoracic aorta aneurysm. Fine. So, the aortas of the hypertensive patient have medial tunica media hypertrophy will be there, which will be associated with some degenerated changes, like again the same pathology, loss of smooth muscle, disorganized extracellular matrix, okay, all those, or in connective tissue disorders like Marfan syndrome, Ehlers-Danlos syndrome, defects in copper metabolism, all those. So there finally, what is the pathology here? Tunica medial damage. Am I right? Yes. Okay. Fine. See, this is what we call as, in aortic dissection, we will get what we call as double banded aorta. That means within the blood vessel itself, we can see another column of blood. Fine. That is why it is called as a double banded aorta. Fine. Now let us see the morphology. The most frequent pre-existing. So, histologically detectable lesion is cystic medial degeneration. I told you cystic medial degeneration is a characteristic feature of, yes, what we are saying in histopathologically is in aneurysm. I'm right? Aneurysm. Okay, cystic medial degeneration is one of the classical histopathological finding in the blood vessel you will observe in Marfan syndrome. Not only Marfan syndrome, it is specific to Marfan syndrome. Even other collagen vascular disorders also, collagen connective tissue disorders also, you will get this. So, before the aortic dissection occurs, there will be cystic medial degeneration. Then only the blood will penetrate the intima and forms a column of blood within the tunica media. Fine? Yes. So, I told you, aortic dissection initiates with an intimal tear. The tunica intima is going to affect first. Okay, it may occur within the ascending aorta. Okay, usually. Okay, but the most common site means, of course, it is in the ascending aorta. Fine. The tears will be transverse. Okay, with sharp edges around 1 to 5 centimeter in length. There is no need that you should remember the length of all this. Just remember, ascending aorta is involved. Okay, the tears will be usually transverse with the sharp edges. Fine. And remember, the dissection can even extend towards the heart, or sometimes it can extend towards the iliac and femoral artery. That means it may extend anterograde as well as it may extend retrograde, and it can also rupture through the tunica adventitia, which may cause a massive hemorrhage. Usually this hematoma will be within the tunica media itself. Sometimes even it can rupture the what we call it as adventitia, and it will cause life-threatening thoracic and abdominal cavity hemorrhage. Fine? Yes. Okay. See, and in some instances, I told you the dissecting hematoma will re-enter the lumen of the aorta through another intimal tear. So, it will create a false vascular channel. That is why it is called as a double-barreled aorta. What is that? Double-barreled. There will be 2 columns of blood vessel. Okay, once you take a cross-section, we can observe that, oh, there are 2 columns of the blood. It will look like a double barrel. Okay, what is the reason for double barrel? The dissecting hematoma. So, once again, I will draw that again. So, this is the blood vessel. This is the blood vessel. So, the blood is entering here. The blood is entering here. The blood is entering here. Okay, this is the intima. This is the tunica media. The blood is entering the tunica media. It will re-enter again the lumen of the blood vessel. Okay, from the tunica media, it will re-enter the lumen of the blood vessel. It will form again another column of blood here. So, it looks like a double-barreled aorta. Okay, yes. Fine. The another most important point that you have to remember here is that the classification. What is that? Classification. We follow 2 types of classification. One is called DeBakey classification, another one is called Stanford classification. Very, very important. Most frequently asked question in your PG entrance exam, that is DeBakey classification, and another one is called Stanford classification. What is this DeBakey classification? DeBakey is the name of a scientist. We have type 1, 2, and another one is what we call it as type 3. Okay, but now what we are following is the Stanford classification. Stanford classification we have classified into type A dissections and type B dissection. What is type A dissection? It is the dangerous and the most common dissections are type A dissections. Okay, yes, type A dissection means they are proximal lesions. This will involve the ascending aorta and descending aorta, or just the ascending aorta only. See, you can see here. This is the involvement of ascending aorta. Okay, ascending aorta. Ascending aorta. This is descending aorta. You can see here both ascending as well as descending aorta both are involved, or only the ascending aorta is involved. So these are proximal lesions. What are these are called as? Proximal lesion. This is called as type A. according to Stanford. See, type A according to Stanford, or type 1 and type 2 according to DeBakey. So type A means ascending aorta or descending aorta or both. Simple. Fine? Yes. Then DeBakey, that is Stanford classification. DeBakey, type 1 and type 2 actually comes under type A. So what is this type 1? Type 1 means DeBakey, both ascending, both and descending is involved. Only ascending is involved, we call it as type 2. But now we don't use that much, but still theoretically this question is asked again and again. Type 1 means both is involved. Type 2 means only ascending aorta is involved. Type 1 and type 2 comes under Stanford classification. Type A dissection, which is more common, dangerous, and they are proximal lesions. Fine? Yes. Then coming into type B. What is type B? Type B means it is Stanford classification. As per type B of Stanford classification, the lesion involves only the distal part. So that is why these lesions are called as distal lesions. Type A is proximal lesions. Type B is distal lesions. Remember, in distal lesions, what? Only the distal portion. That is, only the descending aorta is involved. Only descending aorta is involved. This actually comes under DeBakey type 3. Okay, you can see in this picture DeBakey type 3. Okay, here only the descending aorta is involved. So that is why distal lesions. Okay, distal lesions are type B according to Stanford classification. Very good. Yes, distal to subclavian artery. Distal to subclavian artery, that is type B Stanford, or type 3 DeBakey. Fine. What is the classical clinical symptom? Yes, this is the most important area you have to focus on. There will be sudden onset of excruciating pain, which will begins in the chest, anterior chest. It will radiate back to the scapula. Okay, and the pain can be confused with the myocardial infarction. But I am telling, aortic dissection, how will you classically describe that pain? It is the worst chest pain that the patient has experienced ever in his or her life. This is the classical thing. Okay, remember, the worst headache a patient has experienced ever in his life is the headache due to subarachnoid hemorrhage. Similarly, the worst chest pain that the patient experienced in his life, this is how, sir, I have not experienced such an severe chest pain ever in my life. That is the classical way the patient describes the chest pain because of aortic dissection. Fine. What is the most common cause of death? The rupture of this dissection, which will lead to life-threatening pericardial, pleural, or peritoneal cavity hemorrhages. Fine. Yes. And sometimes cardiac tamponade, aortic insufficiency, or renal mesenteric artery ischemias, vascular obstruction, transverse myelitis because of spinal artery involvement, and myocardial infarction. All these are causes of death. Then coming into type A dissection, we can manage them with either surgical plication of the tear. We can, that is, correct the intimal tears. Okay, we can correct the intimal tears, and at the same time, by using antihypertensive therapy. Fine. Yes. Whereas type B dissections, in type B dissection, I told you the more common, the dangerous one is type A dissections. Why? Because both the ascending or descending aorta is involved, or sometimes only the ascending aorta is involved. Whereas type B dissection, only the descending aorta is involved, so it can be managed conservatively. There is very high survival rate compared to type A dissections, okay, or type A lesions. Fine. Yes. So these are about aneurysms and dissections. Definitely, if I don't know whether aneurysm is asked or not, but for MCQ purpose, you should know what is the pathology, what is cystic medial degeneration, what happens in Marfan's, what are the features, all those. Okay, what are the different variants of abdominal aorta aneurysm, what are the risk factors for abdominal aorta aneurysm, and the second thing, aortic dissection. Okay, in aortic dissection, here I will be asking a question that in aortic dissection, actually, what is the pathology? Where the pathology is in the, I told you in aneurysm, the pathology is in tunica media. Here comes the question in aortic dissection. What is the pathology? Whether it is the intimal pathology or medial pathology? Answer is intimal pathology, because it is this intimal tear which is responsible for the blood to leak, and this blood will re-enter back to form the double barreled aorta. So the pathology, this is a very, very confusing question. Students will think the blood is accumulating in the tunica media, so the pathology is the tunica media. No, it is not. The pathology is not in the tunica media. It is the tunica intimal tear. So the pathology is in the tunica intima itself. I am making it very clear. Tunica intimal pathology leads to aortic dissection. Okay, remember the DeBakey classification, Stanford classification. Okay, you can refer this picture. Okay, Stanford classification and DeBakey classification. Out of that, they will ask you what is the most severe or dangerous. Answer is type A. I told you, now we are using only this Stanford classification only. DeBakey we used it earlier, but still for theoretic purpose you should know. Okay, yes. So with this, I have finished aortic dissection and aneurysms of abdominal aorta and thoracic aorta aneurysm. Thank you.